Okay, so let's go ahead and get started. We'll be speaking about Regenix in general. This is the nation's most advanced non-surgical stem cell and platelet treatment for common injuries, arthritis, and spine conditions. And we'll get into the nitty-gritty of all that. Let's get into a little bit of an introduction. Regenix Tampa Bay, we have two facilities, two main facilities, one in Tampa, North Tampa, off of Fletcher, and then we have a facility in Sarasota, and that's where I'm speaking to you from at this time. We also have a consultation office in St. Pete, but all the main procedures happen in Sarasota or in Tampa. We're made up of four different doctors. You can see I'm here on the left side of the screen. My name is James Lieber. We also have Dr. Amoroso to the right of me, and Dr. Ronald Torrance, and Dr. Ignatius Pappas. I'm really proud to have this exceptional team of doctors working here. We're all practicing the same type of medicine and all at the highest skill level available. So I want to talk a little bit for a moment about what chronic pain, what's going on with chronic pain in the United States. This is really an epidemic. We have a nation of people in pain and a lot of people who are on narcotics and various other types of therapies. What we're seeing is about 126 million people have had pain in the last 3 months. And about 40 million of those have had pain every single day for the last 3 months. And about 20 million of those have had pain daily for the last 3 months that's severe enough that it's actually limiting their activities or their ability to work. 54 million people, adults, have been diagnosed with arthritis, and about 23 million of those people have arthritis that's inhibiting their ability to do various different activities. I want to go ahead and start with a poll here, and I want to know where you heard. I'm going to go ahead and launch this poll, and we'll see what kind of answers we're getting from the crowd. Give you a few moments to answer that. So the question is, where is your primary area of pain that prompted you to attend this webinar? If you're watching for someone else, please answer for them to the best of your ability. So I'm seeing some people have low back pain, people with hand and wrist problems, neck problems, knee pain. Another knee. Give me a few more moments. We have a few more people left to vote. Okay. Okay, so we're seeing, this is typical to what we see in our practice. We're seeing the majority of the people, I wouldn't say the majority, but the most hands raised and the most answer were for knee. We're also seeing low back, neck, hand and wrist, probably a thumb, and one is voted in the other category. I appreciate you taking the time to do that. We'll have a couple of these as we go along. I'm going to go ahead and end that poll at this time. Okay, so what I'd like to do is move on to the next slide here. So for those of you who are experiencing pain, I think you've all been through this at some point. You've gone to a doctor, or maybe you first didn't go to a doctor, tried to deal with your pain or your injury on your own. Perhaps you took some over-the-counter anti-inflammatory medications. You kind of eased up on your activities for a period of time. You've iced it. Things aren't getting better. Next thing you know, 1 month, 2 months, 3 months, 6 months have gone by, and you're trying to figure out how to get past this pain. You may have had a traumatic event, or maybe you didn't have a traumatic event. You just woke up one day or twisted the wrong way, and all of a sudden this pain would never go away. What you see is that there are different ways. You'll go to your doctor, for example, and they may refer you to physical therapy, may prescribe you certain kinds of medications, anti-inflammatory drugs, or perhaps narcotics. Perhaps you get a cortisone injection, maybe some bracing is recommended, and perhaps you go see an acupuncturist or you get some manual medicine or you change your lifestyle in some way. And let's say all of that is not really working. So what do you do next at that point? Either you continue with the pain medications or maybe you move on to surgery. And maybe you get some sort of sophisticated surgery that has robotic or computer assisted controls. And that would be one option. And what we're going to be proposing today, and what I'm going to be speaking about throughout the time of this webinar, is the fact that there are other options. And we believe that this box here on the right, lower corner, image-guided regenerative non-surgical procedures, are really a viable option to fill in the gap before having to make a decision about surgery. Or, as a matter of fact, we see a lot of people who have already had surgery and can still benefit from these procedures. So we'll talk more about that. So sometimes, cortisone injections can be a good option. Oftentimes, they're not. Really, corticosteroids are frequently used by physicians to reduce inflammation. So these are the most powerful anti-inflammatory substances we know, cortisone. However, it also happens to be the most degenerating substance we know. So most of the conditions that we see and we're treating, and I'm going to get into those here shortly, are degenerative conditions like arthritis, rotator cuff tendon tears, disc herniations or pinched nerves in the back, maybe tennis elbow or thumb arthritis, so forth. All these different conditions that we treat are degenerative conditions. That is, the tissue has gotten weaker and maybe inflamed, but certainly weaker. And what cortisone does is actually degenerates that further. So it may remove the inflammation for a period of time, but it does it at the expense of the tissue. And what we know from research is that it hinders the body's own mesenchymal stem cells, or the stem cells that are necessary to repair that tissue. So cortisone not only weakens the tissue, it hinders the stem cells' ability to heal the tissue, and it will have systemic effects on other tissue as well. So we feel that cortisone in general is not the best strategy. So the answer is sometimes yes, but most of the time, no, cortisone is not the best option. And now let's just take a little sidetrack here and talk about surgery for a moment, because it's so commonly done for so many different things. Orthopedic surgeries are amongst the most common surgeries in the country. And we feel that a large majority of these are actually unnecessary. And so interestingly, the British Medical Journal published a paper, and they have a funny way of phrasing things. They say there's scandalously poor evidence base supporting common orthopedic procedures. And a quote out of that research, which was basically compiling all the research that has come prior to it, was that the evidence base for orthopedics compares unfavorably with other fields of medicine. And only about 20% of the procedures show that surgery is actually superior to a non-operative alternative. Just to take that a little bit further, in 2014, we know that Americans spent about an estimated $45 billion on surgery for chronic low back pain, and about $41 billion for scopes, arthroscopy for chronic knee pain. So a new meta-analysis that just came out shows that there's really little evidence to support the use of invasive interventional procedures for chronic knee pain, like arthroscopic surgeries. And low back pain, different types of procedures that are commonly done for low back pain, like burning nerves or going into discs and adding heat, or different types of procedures like that. Unfortunately, this meta-analysis showed that those are generally ineffective. And for knees, the average improvement was actually greater in the studies that showed that were comparing it to fake surgery, sham surgeries, than the ones who actually underwent the real surgery. And for meniscus tears at this point in time, for knees, there have been 7 clinical trials now that show that a scope for a partial meniscectomy is really no better than physical therapy or fake surgery. And as a matter of fact, we believe it makes things worse. It's been shown to accelerate arthritis in many cases and make someone possibly more likely to need a knee replacement down the line. And when you think about lumbar fusions, which are an incredibly common surgery in this country, comparing that to non-operative procedures or management for treatment of disc related pain in the back, This was a recent, what's called systematic review and meta-analysis. That's looking at all of the randomized controlled trials prior. Really, they showed no difference between doing a lumbar fusion when you compare it to doing no surgery at all. And we know once you've had a lumbar fusion, that is, you're fusing the segments of the spine, maybe one or two. I actually saw two patients today. One is fused from T2, the thoracic spine, all the way down to the lower lumbar spine at all the way to the sacral base at S1. And I saw another patient who was fused from T9 to S1 today. Problem with those, perhaps they may get some relief in the area where the fusion occurred. The mechanics are so altered in the spine at that point that the segments above and the segments below become problematic because of the biomechanics. There was no ability to move in those fused segments. Therefore, the loads are transferred to the segments above and below. This is the reason why these two patients in particular ended up having fusions. They had a fusion at this level, for example, and then they had to go up to the next level and next level, and that occurred over the course of years. One of them in particular ended up having an infection from one of his fusions where they had to go back in a second time, open him up, flush it out, put him on IV antibiotics for a long period of time. It was quite a traumatic event. All right, let's talk about this new field. We're calling it interventional orthopedics. I just wanted to give you a little introduction into what it is that we do and how it's different than what has been done previously. So what is interventional orthopedics? So this is a different strategy than what we've just been talking about in terms of surgery. This is a tissue preservation strategy. We're trying to preserve the tissue that's damaged. So if you have a tear of the ACL ligament in the knee, or the meniscus is torn in the knee, or the labrum in the hip, or the disc is torn in the back, rotator cuff tear, etc., what we want to do is preserve that tissue, and we want to avoid things that are going to hurt your body, things like narcotics, which we know there's an extensive epidemic going on, cortisone injections, which I already discussed briefly before, chronic use of anti-inflammatory drugs, which are so commonly done, and they're sold over the counter, and people would then assume that those are then a low-risk type of medication. But it's been shown that use of these medications, these anti-inflammatory drugs in the categories like Aleve and ibuprofen and meloxicam, these kind of things have been shown to increase the risk of heart attacks and strokes, increase the risk of, and that's really with not an extensive time period. That could be done, that risk can actually occur over a short period of time. And we know that it increases the risk of gastrointestinal bleeds, which, I was part of admitting patients to the hospital for years who'd come in with bleeds in their stomach from use of these type of medications. And then also kidney problems, possibly liver problems. And then surgery. And there are certainly issues associated with surgery. First of all, many of them may not even be effective. Secondly, once you've had surgery for a particular condition, and I'm not saying that all surgeries are not indicated, but we believe the majority of them are not necessary. But once you've had surgery, you're really never the same in that area. I've had major surgery. I'm sure many of you have had major surgery, and that's, I'm sure you can attest to that. So what we're proposing, and what we've been doing for quite a number of years, is using orthobiologic material. So when I say orthobiologic material, I'm talking about platelet-rich plasma, which comes from the blood. And I'm going to talk to you a little bit about what that means and why platelets may be an effective strategy. Also, stem cells, which we can get from you or the patient. We use those as injectable materials and to facilitate the healing. And we're basically talking about bone, tendon, ligament, muscle, or cartilage. And the key, and what's quite important to us at Regenerative, is the precise placement of these different materials. So we want to take that material, harness your body's own ability to heal, isolate that, concentrate it, and place it into a liquid solution that I'm able to then inject. All the doctors are highly skilled at doing this in our practice, at placing that injectable material into the damaged structures using image guidance. Really, really important to be able to use fluoroscopic, which is X-ray guidance, or ultrasound guidance. This is really where the skill comes in. Skill comes in several places: in the assessment of the patient, in our evaluation, in the laboratory processing of the material, and as well as in the placement of the material. And once we're able to do this, we feel, and what we're seeing and our data supports, is that we're able to get this tissue to heal, and we're able to get somebody who's in pain back to the level of function that they desire, able to do the things that they want to do. Perhaps it's traveling, perhaps it's playing with grandkids. And we'll talk a little bit more about that here in a few moments. So the questions that I think are important for you to answer, to think to yourself, is what do you do? What do you want to achieve? What is it that you can do that you used to be able to do? And what will happen if you don't do anything at all? How do you see your future here in the next months to years? And what are your options? And I guess it's also important to think about why is it that you want to achieve this, and why now? Why is it important to you? And those are the things I want to know when I'm interviewing a patient, because I want to be able to help them achieve those things that they want to achieve. We want to understand what it is that what are your goals, and my goal then becomes to help you achieve your goal. And how are we going to achieve this? Are we going to do this through medications? Are we going to do this through injections with cortisone or surgery? Or are we going to do this through natural remedies, such as using stem cell and platelets, but doing it in a very sophisticated and highly skilled way? We know we have a lot of patients who like to play pickleball. We have a lot of patients who want to play with their grandkids. And the couple on the right, there's a real couple that we've treated, and their hobby is to ballroom dance. So I want to open up another poll here, and I want to ask you, what worries you most about your condition? Let's go ahead and pull up that poll. So we're going to go ahead and pull up the poll. I'm going to launch it now. And the question to you is, what worries you most about your condition? And you can answer more than one of these. Is it that you're unable or limited in playing a sport or exercising? Are you unable or limited in your ability to walk for your daily life? Are you unable or limited in playing with children or pets? Maybe you're unable to or limited in using stairs, or unable or limited in your ability to travel. Or maybe it's you're unable to lift or carry objects in your daily life, or maybe it's some other thing that I don't have listed here. I'm curious. That helps me understand who I'm talking to and how I can best help you. So we've got a fair amount of people, looks like, who I'll kind of give you the percentages right now. About 83% are saying they're unable or limited in playing a sport or in exercising. And then we're kind of split in people who are unable to walk for their daily life, or play with children or pets, or using stairs. And then we've got about 30, looks like it's, numbers are shifting around a little bit, but we're seeing that a fair amount of people feel limited in their ability to travel. And that's something I hear very commonly in my interviews with patients and in our consultations. And then some people are struggling with being able just to lift or carry objects in their daily life. Presumably that's more of an upper body issue. Good. I appreciate everybody participating. Anybody else want to chime in? We have some other people who haven't had a chance to answer that question. Okay, I'm going to go ahead and end that poll. All right, let's go ahead and we'll close that out. And let's move on with the talk here. Good. We'll have some other questions as we go along. Okay, so what I'd like to do is, we talked a little bit about what it is that's bothering you. I'd like to show a small short video of a couple, that same couple that was the ballroom dancing couple, so that you can see what their story was like and their experience with Regenerative. Let's go ahead and see if this can load.
I guess we always have. Right now our passion is...
Start from the beginning here.
Don and I love outdoor activities. I guess we always have. Right now our passion is dancing. What we really like about dancing is two people moving together.
Two people moving together to music.
The dynamics are amazing.
It's an amazing thing, almost mystical. And it doesn't always work, but often it does, and when it does, it's just wonderful.
We were both professors, Don, in mathematics and I in statistics. I remember in dance classes doing basic moves like putting weight on the knee, not being able to do that, pushing back, couldn't do that. The knee would lock in place for hours at a time. Basically, there was a condylar flap that was getting caught in the joint.
We call it a flap tear, where a piece of cartilage is loose and you're getting caught at different times. Additionally, she had pretty significant arthritis in that knee.
When it started locking in place, I think, things were pretty much critical and I had to do something. I knew the conventional option would be a knee replacement. Didn't want to do that at all.
She came to me wanting to see if we can do anything that was non-surgical.
Don and I had read about Dr. Centeno's work years and years ago, and so I just thought to maybe look into the idea of stem cells to see where that had progressed. And I was kind of surprised to find that, Regenerative had an entire program, and even more surprised to find that there was a physician locally 2 hours away who performed the procedures. That was Dr. Lieber, and we were very happy to find him.
We were able to perform a stem cell procedure on her.
I can do the things I couldn't do before the procedure. I can put weight on the bent knee. I can push back. I can move forward. It's actually very good functionality.
I'd say we've been kayaking for about 15 years.
Rivers where we live are just incredible.
Don came to me with a problem with his shoulder. He was not getting better with physical therapy. He was having significant shoulder pain. When we did our evaluation with him, he had a large rotator cuff tear. Having seen Marie's success with Regenerative, I went to see Dr. Lieber and decided to go ahead with the shoulder procedure. We went ahead and did a stem cell procedure on his right shoulder. I can do anything in life that I really want to do. Have essentially full range of motion. I really couldn't be more happy with what happened.
I have been a soccer referee for the last.
Okay, let's go and bring back up the PowerPoint. Let's see, okay. Let's see, can I have some people let me know if they were able to see that video okay? Looking for just some comments on that, appreciate it. Okay, good. I think it looks like that video was seen. Nope, didn't see a thing, only audio. Huh, okay. Hard to understand and never saw video. Okay, well, we'll have to skip the future ones because that was, that didn't work out. So can everybody see my screen now? Showing a picture of 2 people in a kayak. Let's see if anybody's able to see that. Yes, okay, thank you. Appreciate that. We'll have to skip over those videos, unfortunately. I'll have to figure out how to do that in the future. Okay, so what is regenerative medicine? Let's talk a little bit about that. So what we're talking about is a field in which the process of replacing or regenerating human cells, tissues, or organs, basically to restore or establish normal function. And when we're talking about Regenix procedures, we're really focusing on tendons, ligaments, muscles, joints, meniscus, cartilage, and nerves. These are the things that we're focused on. And I'd like to step back for a second, just discuss with you what it means to heal, how your body normally heals. So if you can picture a cut on your skin, everybody's had that before, so you can picture that. You'll notice that blood rushes to the area. I'm going to go ahead and go to the next slide because it puts it into words here. So we see the first phase that happens when platelets will rush to an area where there's a cut, and their purpose is to form a clot and stop the bleeding. Then they open up, and they have a secondary, very important function, is to release the internal components of the platelets. and those are called growth factors. And the growth factors are it's basically a laundry list of these different growth factors that are responsible for orchestrating healing. That whole process is what we experience as inflammation, and that's the first phases, the first 4 days. What I like to say is the growth factors within the platelets, they're basically like phone calls to subcontractors. Each growth factor is making a phone call to the carpenter, to the plumber, or et cetera, and they're bringing the resources over needed to repair the tissue. So all that happens, all those phone calls happen within the first 4 days. And interesting, one of the phone calls is actually made to stem cells. We're going to talk about what a stem cell is, but I can get a little ahead of myself here. Basically, they are baby cells that live on ready reserve, and they live in high concentration in the bone marrow, in the back of the pelvis. They do live in fat tissue, and they're also plastered to blood vessels in different places. So when they come to an area, those stem cells can turn into that skin cell, for example, in the skin cut example, or they can become like the general contractors, and they can use the information and the growth factors as a way to orchestrate and sort of take over and manage the repair process. So the first phase, I'm going to start pointing here. The first phase is that inflammation phase. And then after that, 4 to 5 days, we start to see the cell proliferation. That's when all the resources and all the subcontractors actually start bringing in all the materials. And then that can last for about 4 to 6 weeks, 4 to 5 weeks or so. And then there's a remodeling that occurs. Once all the materials are there, it has to be done in a particular order, just like you would do a renovation project in your home, for example. And that remodeling can occur from anywhere from 5 to 12 months. And it can take some time, but the body does this naturally. It knows how to do this. You don't have to tell it how to do this. However, as we get older, there are issues with the way we do with the way our body actually does this, and that's when chronic injuries can develop, even without having any trauma whatsoever. So these phases are not distinctly separate, and they overlap in their time of onset and activity, and people vary a little bit in terms of that, and we see that clinically all the time. Anyway, that's the normal way the body should heal. Okay, so move on. So when you're young, you have phenomenal growth and healing, and you have very little wear and tear. And your body has to be able to keep up with the everyday wear and tear. And what we see as you get older is that the growth and healing component is not as good, and the wear and tear starts to outpace your body's ability to keep up with healing. So all you have to do is have another birthday, and as time goes on, the tissue just gets weaker and weaker. And what we're trying to do is to balance out these scales. All right, so we're starting to talk about this here. The platelets are the early responders to the site of the injury, as I was discussing, and they form the clots, as you can see in the picture here. They release those growth factors, and those are the signals that call in the resources to rebuild the tissue and to strengthen that tissue. And so the instructions to orchestrate wound healing are contained within the platelets. And the stem cells are those baby cells that I mentioned that can turn into other types of cells. They're on ready reserve, and some of them convert into new tissues, and others act like the general contractors in the area, like I mentioned. And they also help orchestrate the regeneration of tissue. Stem cells are more powerful than platelets alone at actually accomplishing this. And another way to think about them is they come to an area that's been injured, and they help the local crew with giving them espresso shots so that they can function a little bit better, have a little bit more energy. The biology behind that is quite interesting. Okay, so where are we with this in terms of these? How do we utilize these procedures? Well, I want to step back for a second. Let me explain the concept of prolotherapy. Prolotherapy is really the grandfather concept to what we're doing today. So prolotherapy began as a technique and as a concept back in the 1930s. There were two famous orthopedists who were trying to figure out how to strengthen loose ligaments or ligaments that were torn without having to actually do surgery. So they experimented with injecting different types of materials. And what they found was anything that was mildly irritating to that tissue, when you inject it into it, would cause that tissue to release some of its own growth factors. And then it was able to actually get stronger. And they found that if you did that repeatedly, maybe once a month, every 6 weeks, something like that, they found that over the period of time, maybe 5, 6 times, they were able to get that tissue to strengthen maybe 30 to 40% with just this technique alone. So that concept seems like a simple concept, but it was never something that remained as mainstream in medicine. As a matter of fact, shortly thereafter, cortisone was invented and pushed prolotherapy conceptually to the side, even though there have been physicians who've been doing this on the fringe of medicine for many, many decades. Really, cortisone is what became the most popular injectable material, and to date, that's still the case. And that's what insurance will pay for, is cortisone. We talked about the problems with cortisone, and conceptually, it's the opposite of prolotherapy, right? Prolotherapy is trying to strengthen tissue as a concept, and cortisone is trying to get rid of inflammation, but at the expense of the tissue, and it gets weaker. So typically what's been used over the years for prolotherapy has been high concentrations of sugar water, of all things. That's actually irritating enough to the tissue to do this, to have this effect. But technique-wise, this has always been a blind injection technique. In other words, physicians learn how to feel and inject the tissue in different ways without actually ever looking at the tissue. It's a big breakthrough, I think, that occurred in the 1990s with fluoroscopic or live X-ray guidance. Being able to place a needle using live X-ray became a very important skill, mainly to inject cortisone for a period of time. And as a matter of fact, it's very, very important to use this type of technique, in particular for spine-related procedures in the neck and the low back, for example. And then ultrasound guidance became more popular in the 2000s. That is, being able to use an ultrasound equipment, sonogram, things you've heard about for looking at babies or liver or abdomen or heart. With the proper skill and training, a doctor can actually look at your cartilage or your meniscus or your rotator cuff, for example, and guide a needle into the tissue. So it's helpful for actually looking at the tissue to see what's wrong with it, and also for placing a needle into that tissue accurately and safely. But that is actually probably a harder skill set than using the other. And that's what I think is one of the biggest barriers for people doing this at a very high level. Then we started to understand that maybe there's some better material we can use other than sugar water. Perhaps we can use somebody's own platelets and growth factors, concentrate that, and use that as the injectable material. And so what we see is back somewhere in the 90s, late 90s, dentists started to use this and published papers on using this for gums or bone surgeries in the mouth. There was some horse racing cases that were used in 2003, and then a human publication, the first one pertaining to an elbow, in approximately 2006. And then this really got a lot of attention there. I know someone on there is a big Pittsburgh Steelers fan. Back in 2009, about 2 weeks before the Super Bowl, one of the star wide receivers hurt his knee, injured a ligament in his knee, and his team physician decided to inject this, what they call platelet-rich plasma, concentrated platelets from his blood, into that ligament to try and get it to repair. And then lo and behold, 2 weeks later, Hines Ward was in the Super Bowl, and he ended up being the most valuable player for the Super Bowl. I certainly wouldn't have let him play at that point, but that's what the team physician chose, and it was the right choice for them at the time. And that got a lot of media attention. And so that's only been 9 years ago, and there's been a lot that's happened in that time period. Stem cell injections, actually the first stem cell injections in the United States occurred in 2005 by Regenerative physicians. But then the research was a little bit slower to start coming out as compared to the research for the platelets. And then there's a related field. It's kind of different, but somewhat related, is that there is the combination of surgery with use of stem cells. And our goal is to keep people away from surgery, and we believe we can do that, and our data supports that we can do that. Probably about 70% of all orthopedic common surgeries can be prevented with our procedures. But you can do, and there are certain instances where we'll recommend to you that maybe the best option for you is surgery plus stem cells. But this is really not that commonly needed. And in most cases, we see you don't need that. So we talked about platelet-rich plasma and the growth factors. And now there's quite a bit of evidence supporting its use in a lot of different settings, for knee arthritis, for various types of tendon problems. The version that we use as part of Regenerative is called super concentrated platelets. We have a different name that most people call it as PRP, platelet-rich plasma. And one of the reasons is there's a lot more we can do with the platelets than you can from a typical typical way that they're prepared. Typically, they're prepared by using a centrifuge, and within a short period of time, maybe 14 minutes or something like that, you have a concentrated platelet solution. And this is what I used to do when I first started doing this, maybe 9, 10 years ago. But since joining Regenerative, we have a completely different way of doing this. Other than spinning, we have a 1,000-pound sterile hood where a highly trained laboratory technician can make very specific individualized products depending on what it is I ask them to make. So depending on what kind of tissue I'm injecting, depending on the age of the person, depending on all the different structures that we're trying to treat, we may make the platelets in different ways, more concentrated, less concentrated, leave white blood cells in or take them out, red blood cells in, take them out, so forth. That allows us to make a very individualized and more powerful product. So that's why we give it a different name, super concentrated platelets. This is a video I wanted to show you. This was, I'll just tell you a little bit about her. This is a Broadway performer. She's currently on Broadway, and she had a neck injury, and Dr. Amoroso was able to treat her, and she had just a wonderful recovery, and she was able to get back to performing. She was struggling for quite some time. This video is not yet posted on our website, but it will be shortly. Certainly it makes sense to go to our website. You can see a lot of real video testimonials of patients. These are real people, unscripted, who are willing and volunteering to tell us their story and put into a short film type of thing. So this will be available shortly. We'd love for you to visit the website and check out the videos. Check out our Facebook page as well. Make sure you give us a thumbs up and like us and share with your friends. We really are trying to get the word out that this is a better way to help people with their condition. I'm going to spend a few moments talking about adipose tissue versus bone marrow. So there are stem cells that can be obtained from bone marrow, and we can also obtain stem cells, technically we can, from fat tissue. And to some extent, there's a little bit of a Coke versus Pepsi debate. But I'm going to talk a little bit about the differences here because there are some legal issues that need to be discussed and sorted through. So I want to make sure everyone who's attending and who watches this in the future we're all on the same playing field in terms of understanding some of the legalities associated with these things. So I'd like to go ahead and bring up another poll. I want to see, have you, let's go actually run this poll here. Okay, so what I want to know, if, have you attended other seminars pertaining to stem cell treatments for orthopedic issues prior to this one? That's great. Okay, good. So actually, a lot of you are new to this field. We have about 3/4 of the people have not attended a seminar about stem cells. So this will be the first time you're getting some education about it. I think that's great. And about 1/4 of you have attended a stem cell seminar. And I think it's important for both of you, those who have and haven't attended a seminar, to understand some of the basics of what we're going to be talking about. So I'm going to go ahead and end that poll. And let's move on to the next one. I want to know if, for those of you who did attend, there's about 1/4 of you, I'd like to know if the seminar, if the speaker at the seminar was promoting fat or adipose stem cells. So I need to actually pull up that poll here. And I'm going to go ahead and launch that. So have you attended a seminar where the speaker was promoting fat or adipose stem cells? And obviously that's only for those of you who have attended prior seminars. Okay, so actually only about 1/3 of you say that they were promoting. Oh, that got switched around. Let's see. Yep. So about 60% say that the speaker was promoting fat stem cells, and 40% say that they were not promoting fat stem cells. Okay, good. And I want to talk about why that's important here in just a moment. Let's just start with the understanding the concept that there are different places you can get stem cells. You know, we can get stem cells from the patient themselves, or you can get stem cells from someone else and use them in a patient. First of all, that concept of using from someone else is not allowed in the United States. And then just understanding safety in general, understand that your stem cells that we get from you are the safest types of stem cells we can use for your condition. Getting them from someone else is more dangerous for a variety of different reasons. And getting them from embryonic or fetal stem cells, aside from the ethical issues, which there are some potentially serious ethical issues associated with that, is even more dangerous. And this last category we're not going to talk about, but that's probably the most dangerous. So I want to spend just a few moments reviewing this slide. I know it's very, very busy, and just follow my annotation here. Actually, I'm going to go ahead and put on, I'm going to draw on this, I believe. Let's see if I can do that. So I'm going to start off talking about the green on the left side. So what the green represents bone marrow stem cells, and the red represents getting stem cells from fat tissue. So I just kind of want to go down these columns here and help you understand. This really summarizes what the FDA regulations are and what the legalities are. And once we've gone through this, which will take me just a few minutes, you'll have a much better understanding of where we stand in terms of what's allowed and what's not allowed within in the United States. So the first column here, which we call same day, means that we're allowed to take stem cells from your bone marrow, and within the same day, place those stem cells back into some type of orthopedic tissue that we're trying to repair. We're allowed to do certain things to that bone marrow, but not too much extensive manipulation. And that's called the same-day procedure. And that's regulated by the FDA as body tissue rather than as a drug. So you can see here, there's no FDA approval necessary. It's considered to be a tissue that's used in the same surgical procedure, for example. If you look at the next column over where it says advanced, you see what we're doing here is isolating bone marrow stem cells, and then we're culture expanding them. What that means is we're taking them and isolating them and growing them into large quantities. And so technically, that's something that's doable by researchers and scientists. You can take those stem cells and grow them 100 to 1,000 times. And that can be a very, very potent and powerful procedure. But it should be understood that the FDA considers that not to be body tissue any longer. They feel that that material has been manipulated in such a way that it's no longer your body tissue. Therefore, they feel that that needs to be regulated as a drug, and that needs drug approval. So to be used in the United States, this culture expansion of this growth of the stem cells requires that a company goes through 3-phase clinical trials, typically, which may take 5, 10 years, maybe up to $1 billion to get approval to be able to use your stem cells in that way. I'd like to note that Regenerative was doing this in the United States from maybe 2005 till about 2010 or 11, and they were able to grow the stem cells. Nobody really knew the rules at that point, and the FDA stepped in and said, we don't really want you to do this any longer. We feel that it needs to be regulated as a drug, and so Regenerative felt strongly that this was a safe procedure because they had been collecting the data on this from the very beginning, and that it was an effective procedure. So they fought it in the courts at one level. And they made a really, I think, valid legal argument, but they did not win that case. And then they took it to the next level and ultimately found that it was easier for them to find a facility in Cayman Islands where they're allowed to, or where they use that facility and they're allowed to grow and expand those stem cells and actually store those stem cells down there as well. And there's a lot of value to that. And there's probably about, I think, 10 to 12 of us now across the country who rotate down in Cayman who are allowed to do this procedure. But we cannot do this procedure here in the United States. So what we're allowed to do is column 1, same day. And there's a lot of value to this, and this is what we're going to spend the rest of the talk talking about. But be aware, just so you know, that there's opportunity potentially to do this also outside of the country, and we have data on that to show its effectiveness. Let's go over to the next column. We're looking at the fat-derived stem cells. So let's start with the middle one, the one that's called same day. You can see here that when you get stem cells from fat, what you have to do is spin it down and isolate this component at the bottom, and that's called the SVF, or stromal vascular fraction. That part at the bottom, in order to get to it, you have to actually, in the laboratory, add an external enzyme that breaks apart that fat and allows those stem cells to be released. That process of adding that external enzyme and breaking apart the fat, the FDA feels is manipulation of that tissue and feels that that needs to be approved as a drug. And therefore, in the United States, the true use of stem cells from fat is not allowed for orthopedic procedures. There are more reasons than that, that it's against regulation. But just be aware, if anyone is telling you that they can do a true fat-derived stem cell procedure for an orthopedic problem, that they are violating FDA regulation by doing that. What they may be doing, and may be okay through FDA regulation, is just using what's called a simple adipose graft. That is, they're taking the fat, but not really breaking it apart or not fully breaking it apart, and then using that as the injectable material. And that may have some value, but it's not really truly a stem cell procedure. That is considered to be tissue and does not require FDA drug approval. And then finally, the last column, this will be the end of this slide, would be what's called the advanced procedure for fat stem cells. That is, you can take those stem cells, that SVF that we talked about, and just like we did with the bone marrow, you can isolate it and then grow it into large quantities. And that process of growing it into large quantities, again, requires FDA drug approval. So the only true stem cell procedure that is allowed within the United States is a bone marrow-derived stem cell procedure from the patient themselves, used back in that same day as part of the same surgical procedure. And what you'll find is we're going to talk a little bit about how lots of people are making all sorts of different claims about this. And then maybe people will tell you that fat stem cells are better than bone marrow is better than fat. First of all, understand that legally, bone marrow is the only option. And then I'm going to go through some slides here explaining why we believe, having used both of these and collected data on all of these options, why we believe bone marrow is your best choice. Okay, so let me get to the next slide here. How do we erase all that? Okay, I think I figured it out. All right, so what this is a letter that was published by the FDA and is available online. This was a letter that was sent to a clinic in Sunrise, Florida, they were using fat-derived stem cells. They were storing stem cells, which is also not allowed. They were sticking it in IVs, which is not allowed, and they were putting it into people's eyes, and several people had gone blind. So the FDA wrote to them and says, this was back in August of 2017, it said your SVF product, which is the fat stem cells, is considered a drug under this act. And you should take prompt action, correct these deviations. Failure to promptly correct these deviations may result in regulatory action, such as seizure and or injunction. And subsequent to this, they actually did go ahead and submit for seizure and injunction. So be aware that there are many clinics doing all sorts of things out there. And we are clearly in line and understand the FDA regulations, and we feel we're not only practicing the best medicine, we're practicing what is legal within the United States. Bone marrow, in fact, has much more research behind it to this point in terms of the world's research literature. Although there are more and more fat-derived stem cell articles coming out from other countries, still there's quite a bit more research pertaining to bone marrow. And when head-to-head trials have been done comparing bone marrow stem cells to fat-derived stem cells, it seems that bone marrow stem cells are better at turning into orthopedic tissue than the ones that come from the fat. Some people would say, well, maybe if you can get a twofer, maybe you take the fat out and also you get the fat out and you get stem cells from it at the same time. And that may be the case, but be aware that there are actually many more complications associated with taking fat out through liposuction than there are with taking out bone marrow. People believe that bone marrow procedures, they have this impression that it's a painful procedure, but I assure you, if done properly and with care, under image guidance, that is really not much of a painful procedure at all. It's just a little bit of discomfort and a little bit of pressure. I've had it done twice myself, and I can attest to it personally as well. Nobody believes me until after it's done, however. The other thing is the bone marrow has a lot of other things in it. There's a lot of cells within the bone marrow that are helpful for healing orthopedic tissue that adipose tissue and fat tissue does not have. All right. How many of you have heard about amniotic stem cells? So I put that in quotes for a reason, because there are a lot of people who are advertising that they do amniotic stem cells or umbilical stem cells or placental stem cells. Just as a review, the amniotic membrane is what surrounds a baby. You can see it here in the picture. And in fact, at birth, there are tons of stem cells in that tissue. And there's a lot of research going into how to use those kind of stem cells. But in the United States, none of the products that are made and sold to doctors that come from these types of tissues have living stem cells in them. We know that. We know that for a couple of different reasons. We know that because Regenerative has taken those materials, many of them, back to the research laboratory in Denver, and nobody has more experience growing stem cells than Regenerative. They're unable to grow stem cells. There are no living stem cells in those products. Secondly, we also know that the FDA requires that these products have no stem cells, because if they did have stem cells, they would need to go through the standard clinical trials for drug approval, like I was talking about for those other types of procedures. So beware of anybody. I would run the other way if they're telling you they're using amniotic stem cells, umbilical stem cells, or placental stem cells. I'm not saying that these products are not of value. I do believe that they have value. I'm going to talk about that here in a moment. And we've been using it quite a lot over the last year. However, we are upfront with you. This is not a stem cell procedure. What it is a procedure that has it's a fluid that contains a ton of growth factors. Let me get into this a little bit here. So let me ask you if you've ever attended a seminar where the speaker promoted amniotic, placental, umbilical stem cells. Actually, I'm going to rephrase it, and you can answer the rephrased question. The rephrased question I'm launching now, I want you to ask not only have you attended, but have you seen advertisements about it? That would be the other question. Have you attended a seminar, or have you seen advertisements where the speaker is promoting amniotic, placental, or umbilical stem cells? Okay, thank you. Appreciate your participation. So about 70% of you said no. So this maybe is a new topic to you, and I'm presenting something that you didn't know was a problem. And about 30% of you say yes, you have. So appreciate everybody participating. And let's go on to the next slide. So this is what we're seeing a lot of. This is what really has to stop. You can see on the left-hand side of the screen is a full-page ad that is advertising a free educational seminar about stem cells. And when people attend these seminars, we know that they're talking about amniotic, placental, umbilical, and again, in quotes, stem cells. And what we're seeing is these large marketing management companies working with chiropractors across the country to set up these programs where the chiropractor hires a physician's assistant or a nurse practitioner to come in and do these injections, because chiropractors are not allowed to do injections by their licensure. The nurse practitioner or PAs are allowed to do injections, but their skills at doing that are not necessarily at the highest level in terms of using image guidance. And then they still need to have a medical director who signs off on that. So there's oftentimes the stories we hear are MDs or DOs who are off-site, maybe even retired, who are making a little bit of extra money signing off on these records. And so these are basically large management groups, marketing firms, that are then reaching out to the chiropractors and creating this model for them as a way that they can make money. And they're marketing these as stem cell procedures. And in some cases, we're seeing charges for this that are just absolutely through the roof, some that blow my mind. We know that there's and in the case I'm thinking of is actually not a group like this, is an interventional pain doctor in St. Pete Florida, who's offering amniotic stem cells. We know that he's placed it into the knees of 90-year-old men. I know of a patient, and charging $20,000 for something like this. This is really criminal. And we've even heard cases in the $20, $30, $40 to $50,000 range in the United States, and some of which are by board-certified physicians. This is a major problem. Again, I do feel that there's some value to these products. We've seen some good results in adding this to a person's own stem cells or platelets, or in some cases using it alone. But we're going to charge you what's the appropriate amount, and we're not going to tell you that this is a stem cell procedure. And in these cases, what we're seeing is that everyone is told that they're a candidate. And this is a problem. Without data, you can say whatever you want. We're the only ones who've been collecting large amounts of data, which I'll tell you about in a little while. And we can sit in front of someone and tell them, look, these are your chances of benefit. You are a candidate. You're not a good candidate. How likely you are to benefit, and provide realistic expectations. Every single procedure has a success rate and a failure rate. And we are board-certified physicians first. We're here to serve the patient first. And we're going to give you and talk to you about all your options and talk to you about the realistic expectations associated with any of these procedures and where the technology is today. This is just a quick little interesting case about fetal stem cells. This is a gentleman who, I'm going to point here. This is a man who had a stroke, I believe, and this was published in the New England Journal of Medicine in 2015. And he had some deficits from the stroke, and he traveled the world trying to get different types of treatments, stem cell related treatments, and he spent close to $300,000, it's reported. He ended up in Mexico, get an injection of fetal stem cells that were actually shipped from Russia, injected into his spinal canal. And 6 months later, he was actually better in terms of his walking. He was actually getting better. But the improvement didn't last very long, and very unfortunate situation. He ended up having another injection, and then something disturbing happened. And then here's a quote from the article. The surgeon gasped when he opened up this patient and saw that what was in his spine. It was a huge mass filling the entire part of the man's lower spinal canal. And I'm going to go ahead and show you the image. If you don't like gory pictures, close your eyes, please. So what we're seeing here is, on the right-hand side, is a picture of a very large mass in the spine. And what this represents is what's called a primitive tumor. That is a tumor we know that can only have developed from fetal stem cells. And so it was clearly from the procedure that he had. The point here, and the point I'm making, that we don't deal with fetal stem cells and we don't deal with non-orthopedic problems. The point is, beware that there are people doing things that they shouldn't be doing, that fetal stem cells are something that we cannot control if they're truly fetal stem cells. And again, as I was mentioning, there truly aren't amniotic stem cell, placental stem cells, umbilical stem cells being used legally in the United States. Okay, so what do you want to ask at your stem cell seminars? You want to know what the stem cell source is. Now you're educated about that. You want to know if they're using an amniotic or cord product, even if that has live cells. You're educated about that. You want to know where their published research is. You don't want to see research that they're showing you from someone else in Europe that's using live amniotic stem cells, and then somehow they're going to tell you that what they have in their vial is something that is related to what was shown in that research. That's a bait and switch. So now you're educated about that. Who is a candidate and what is your failure rate? They should be able to point you to research that shows that information, if they have that information. If they don't, they need to be honest about that as well. Who's going to be performing the procedure? This should be an MD or DO, and what type of equipment is used. They should be not only using live X-ray and live ultrasound, they need to be highly skilled at that. You can have the equipment and not be very good at using it. So these are the questions you need to ask, and hopefully you can go into this with more education. All right, so I'm going to move through this quickly. We talked a lot about the amniotic stuff. We use a particular product by a company called MiMedx. They've never done any bait and switch. They've always been honest about what they do. They have actually FDA approval to be used in knee arthritis. We can use it in other conditions. And it's been a product that's been used in the wound care world for many, many years as a graft to try and help wounds that won't heal, and they're able to do that. So they have strict standards. We feel it's a valuable product. and they have a good dedication to research. And what do? They have a lot of growth factors in them, and they're what's called immunologically privileged. That means your body can't really react to them. You don't need to match blood types to use it. So there's some value there. And what are they composed of? They're made of things called collagen or an extracellular matrix. They have regenerative molecules, a lot of the growth factors and special types of enzyme inhibitors that can help with repair. So this is typically discarded at birth, as I mentioned. It's not something that affects the baby or the delivery process when they get those materials. This company we know does appropriate testing for infectious diseases. They have a patented cleansing, drying, and sterilizing process, and it's been used, as I mentioned, in wound care and surgery over 1 million times. And what do they do with stem cells? Well, they've been shown, there's some data to show that they actually help to function as a stem cell magnet. They will pull stem cells and hold them in a particular area. We believe they amplify the healing response, and they can help tendon and ligament reconstruct itself, and we've seen that. And it can act as a scaffold to hold stem cells in an area, and we believe that has some value. So we do combine it with these products, and we have seen benefit from that. So if any of you are listening out there who have had a stem cell procedure with us, be aware that we have new things available to us. There are some other things that I'm not going to even talk about during this seminar. What worries you about having a stem cell procedure? Let's go and take that poll. I'm going to go ahead and launch that poll. So what worries you most about having a stem cell procedure? And you can pick more than one answer here. We'll see how that goes. Are you worried about the safety? Are you worried about the effectiveness? Perhaps you're worried about the value for your money. Maybe the the trustworthiness of the provider. Maybe there are ethical issues that you are concerned about. Maybe some people are concerned about maybe having pain during the procedure or pain after the procedure. I'm going to give you a few moments here. Everybody's looks like a lot of people are participating. I appreciate that. Okay, a couple more. All right, so interesting. So since this is multiple choice, we're going to have some people answering more than one area, of course. So we have about 60% say they have some concern about the safety of this procedure. And I might as well bring this up now. I have a slide on it later. Regenerative has published the largest safety paper in the world pertaining to the safety of the procedures based on our protocols. We cannot speak to anybody else's protocols, but based on the way we do the procedure and the way we are handling things in the laboratory, we have a safety paper that has thousands of people in it over the course of at least a decade, or some people up to a decade in this particular paper, showing that the procedure is quite safe. It's about the same safety as any other needle-based procedure. There's no extra risk associated with using the stem cells themselves. And so the risks of a needle procedure have to do with bleeding, pain associated with the injection, or maybe injecting into damaging an artery or nerve. However, with the high skill and precision associated with the live X-ray and ultrasound, these risks are quite very, very low in a Regenerative doctor's hands. All of you, 100% of you, are concerned to some extent about the effectiveness of the procedure. And I don't blame you. I think it's very important to understand the effectiveness. So this is where I believe Regenerative has a leg up on everybody. Not only do we feel it's more effective, we're the only one who's really tracking the data on whether this is effective. So we have a national database. We know we've had over 70,000 procedures that have been performed. A large percentage of those are part of this national database. That is, there's a team of clinical researchers that are tracking patients who've had these procedures done at Regenerative clinics throughout the United States. And we're tracking safety, but they're also tracking to see how effective these procedures are. So you come and see us for an evaluation, for example, we'll sit in front of you and say, hey, these procedures for your particular condition, your particular age, etc., these are the chances of you having a good result. And we'll have a back and forth discussion about them, make sure you understand what that means. And then I certainly would layer in my experience with that and things that we can do to maybe improve those numbers. But it's important. If you're going to do this procedure, you want to know it's going to be effective. I personally can tell you that our patients have good experiences with this, that they do very well. We have many patients who are willing to talk to other patients about this. Sometimes the results are a little slower than they would like. In some cases, you need to wait 2 months, 3 months, 4 months in order to get the results that you really are looking for. Sometimes we need to boost it. In other words, do a stem cell procedure, for example, up front, and perhaps do platelet booster 6 to 8 weeks afterwards to try and boost that effect. But the majority of the people do quite well, and we can give you the statistics for your specific situation. I personally have had multiple procedures. Unfortunate for me, I've had a variety of different types of chronic pain issues over the years, ranging from neck and low back issues, knees. My right hip was a problem for a couple of years, and my elbow for about 5 to 6 years, maybe even up to 7 years, and my other elbow at a different time. So I've had all these different things that were pain conditions that wouldn't go away. Each of these areas have been treated on me at different times. Some areas required multiple treatments to get me to where I needed to be. I can say with complete honesty that they've all been effective for me, not always with the first treatment, and I'm doing quite well now, and a lot of those conditions are either minimal or completely gone in my case. So anyhow, we have people who are concerned about the value for the money, and we do have some offers for people. Anybody who's attending this webinar, if you want to have a consultation with one of our Regenix doctors here at Regenix Tampa Bay, we will provide you, if we don't take your insurance and we have your name from the webinar, we will provide you with a free consultation. That way you don't have anything to lose. Come in, have a discussion, and we'll see if you're a candidate, if you're not a candidate. I should say also, when you come in, we also will potentially have an offer for you for the procedure as well in terms of a discount. But might as well come in, have the evaluation. It's not going to cost you anything. The trustworthiness of the provider, I think we've talked quite a bit about that. Ethical factors, doesn't seem to be much of an issue for people. Pain during the procedure, we have a lot of different ways to keep you comfortable during the procedure. That's very important to us, and we take that into, that's a very important part of our process. And then pain after the procedure, and we're certainly going to support you through the process afterwards. There will be pain afterwards, and I'll get into that now, I guess. Basically, you can expect about 2 to 3 days where the pain can be intense enough that you need to take a pain medication, and we'll provide that to you. Make sure you have a sufficient amount of pain medication to keep your pain under control during those days. Usually by about a week to 2 weeks, you're already starting to get back to your baseline. And then somewhere around 6 weeks, we start to notice that there's an improvement in your level of pain. Maybe it's 8 weeks, maybe it's 10 weeks for some people, but on average, we see the beginning of the slope of improvement somewhere around 6 weeks. And the interesting thing about stem cells, it goes up. 3 months is usually better than 6 weeks. 6 months is better than that. And usually it continues to have an upward slope of improvement and then plateaus at about 1 year. And that becomes your new baseline. And for a lot of conditions, that's a cure. But for some conditions, it's more of a strategy or a treatment. And in order to maintain that baseline, maybe we have to put a maintenance PRP in there once a year, in some rare cases, twice a year, depending on the condition. But we're able to hold that baseline there for years, and we're having people doing quite well with that, depending on their situation. But for the majority of people, we can keep them at that much better level of improvement in pain and improvement in function for extended periods of time. Okay, thanks for participating in that. That led to a lot of discussion. I'm going to go ahead and end that poll, and I'm going to move on to some additional slides here. Okay. I don't want to spend a ton of time on this. A lot of people are facing joint replacements, and in some cases this may be the best strategy, but for a lot of people it's really not the best strategy. And there are some serious issues you should be aware of when it comes to hip and knee replacements in particular. So let's talk about that. There's by 2030 there are estimates that knee replacements are going to increase in total number by about 673%. That's a whopping amount. And then it's expected that there are going to be revisions of those. That is, a need for a second joint replacement, about 600%. Total hip replacements is going to increase a large amount as well as the revisions. But the real interesting fact here is that the age group that's going to be most affected by this, and who are going to be getting these joint replacements the most is the 45 to 54-year-old group. That seems to be the fastest growing group that's needing these replacements. And so revisions for these people are going to be very, very common. Please be aware that a second joint replacement is even a bigger surgery than the first replacement. And these can cost anywhere up to $50,000 or more dollars. And there's a fair amount of research saying that a good portion of the patients getting these replacements are not even meeting the standard appropriate criteria for getting these joint replacements. But for those that do get it, there's variable results and there are some risks associated with that we can talk about here. And I'm just going to go through my entire PowerPoint slide. You're welcome to stay till the end. I want to be able to have this all recorded so that we can use it in the future. But I do have some additional time here, maybe another 20 minutes or so. So we know that a lot of people do not get good benefit. Those who are the most disabled, that, you know, someone who can't really walk, take any steps at all without severe pain, maybe those are the people that benefit the most from the procedure, because then they can walk at least a little bit afterwards. Some gory pictures, I apologize. I'm going to move on so you don't have to focus on that. Complications. So about 1 in 5 people who get a joint replacement have one of these, at least one of these complications. You can have multiple. So infection, blood clots, a change in your leg length, maybe a dislocation of the prosthesis, a limp. Chronic continued pain is really not uncommon after a joint replacement. The risk of heart attack or stroke is not a small risk, and I'm going to go into the numbers of that in a few moments here. People can have memory issues that develop after these procedures, and they can have allergies to the metal, or they can have metal that leaks into the blood, and they can have toxicity from the metal. So we expect a complication to occur, at least one of these, if not more, 20 to 30% of all joint replacement surgeries. And that's considered common practice. That's normal. This is looking at the risk of heart attack or stroke, and this is really referring to within the first 6 weeks after a major knee or hip replacement, somewhere around a 30% increased risk, not 30%, I'm sorry, 30 times. That's a 30-fold, which is a 3,000% increased risk of having a heart attack or stroke approximately within the first 6 weeks of having a major joint replacement. It is not a small risk. After those 6 weeks, then the risk does come down more to baseline risk. And then in 2008, this particular study showed that there were 5,000 deaths due to a knee replacement in Medicare beneficiaries. This one study showed that 40% of people who had knee replacement were having thinking and memory problems still after 3 months after the surgery. People can have an increased risk of stomach ulcers, a variety of different reasons for that. A lot of it has to do with the stress of the event. Hip fractures actually go up after a knee replacement, the risk of that. More likely to fall after you have had a joint replacement. People can have allergies, as mentioned, to the metals. And a separate issue is not allergy, but the metal itself can leak out. And this was a very big issue with the metal and metal hips, which are no longer being used, but they were being used up until 2011. And people were getting metal toxicity. And that became common practice to then see patients after these surgeries who are having dementia or other kinds of issues that were perhaps related to these metal ions being released into the blood. Malalignment certainly can be an issue if measurements are off. And we know that people get joint replacements. Many of them desire to return back to sporting activities. And many of them can, and some of them can, especially at the beginning. So we know about 65% of them return to sports that they were participating in prior to the joint replacement. But most of those people stop within, by about 5 years or after. So they can do a lot at the beginning, but then there are issues that develop over time that don't allow them to continue to participate in that sport a lot of the time. So many people, and most of the people actually end up pursuing lower intensity and lower impact type of activities. So let's see, I have somebody wanting to ask a question here. Let me see if I can figure that out. No, actually that went away. Okay, so let's go on to the next slide here. So if you're overweight or obese and you have a higher BMI, you actually have a higher rate of needing to have a revision of that surgery, means have it redone early on because of infection, increased risk of infection. And we talked about people moving on to lower activities, activities of lower intensity. And many of the surgeries are actually inappropriate based on standard published criteria. Okay, so a lot of people need to have a second replacement. And a fair amount of people continue to have some degree of pain. Their pain intensity may decrease, but here we have 40% still had a median of 3 out of 10 pain after having had the knee replacement. So you'd hope if after going through something major like that, that your pain would be zero, but that's not the case in many instances. Okay. Removing the meniscus is probably not a great idea. 90% of meniscectomies result in some meniscus being removed. I already talked about how meniscus surgeries in multiple trials at this point are not better than physical therapy or fake surgery. There are some instances in specific cases where having meniscus surgery is a good idea, but the vast majority of them we can treat, and we've been able to do that quite successfully. So once you remove the meniscus, you accelerate the arthritis. And if you decide not to remove the meniscus, but just sew it together, then you have less accelerated arthritis, but you have a higher chance of needing a reoperation for a re-tear. So there really is a lack of high quality evidence that either strategy is a good idea. So we talked about exercise and sham surgery versus surgery in studies. And unfortunately, meniscectomy surgery doesn't compare favorably. So Regenerative procedures, we have many different types of procedures. I wanted to show you this video. It's on the website. It's called Real Experiences with Regenerative, and it's kind of a compilation of various different people's stories. Since we didn't have success with it earlier in the presentation, I just ask that you can go ahead and copy this URL or go to the website and watch the videos. We won't be able to show it here today. I'll figure out how to do it at the next webinar. Regenerative has many different types of procedures. The procedures we're doing are substantially different than what anybody else is doing. It really is a different ball game entirely. We're not even playing in the same field. So Regenerative has multiple facilities throughout the United States and is growing rapidly. We are very conscious of quality control, making sure that the physicians who are part of this network are at the highest level possible. We're trying to have a broad, standardized, evidence-based protocols that anybody attending, any physician who's part of the Regenerative network is going to get the same quality of a procedure. And with that, we understand what our statistics are. So we've had more than 70,000 procedures performed. Greater than 50% of the entire world's research literature pertaining to stem cell injections for orthopedic conditions has been published by Regenerative. There really is no comparison in the world, and Regenerative are the leaders. Everyone else would be considered some version of a copycat. All right, let's do a poll here. I want to understand, and maybe you can help me understand, what is the main factor keeping you from, let's pull this up here. What is the main factor keeping you from having a consultation with a Regenerative physician? Again, this is a multiple choice poll. Is it advice from your doctor? Maybe the doctor said, don't do it. It's not a good idea. We don't trust these procedures. Or maybe advice from friends or family. Maybe finances are an issue. Concerns about safety. Concerns about the legitimacy of the procedure. Concerns about the legitimacy of the doctor. Maybe you don't think there's enough research. The distance to a Regenerative doctor is too far. Or maybe there's some other reason. So if all of you can cast a vote, I appreciate it. To help me understand how to answer these questions for you. Okay. So what we're seeing is 60% of you have clicked on finances as a concern, and I completely understand that. And in terms of, I think probably the answer is probably more value, right? If you knew for sure that this would work, then you would feel more confident in being able to put up the finances for that. So I totally understand that. We are working hard. Regenix is the only organization that has the ability to work with insurances. Now, we are not taking, many insurances are not covering this, of course, but Regenix has been working with large self-funded, self-insured employers to get them to understand the statistics and their potential cost savings. And they've had quite a bit of success in getting companies to cover these procedures for their employees. So we've got about 5 million lives across the country that are actually covered for Regenix procedures. We're also seeing some Christian kind of these cost savings, cost sharing plans like Samaritan Health is covering these procedures for their members. So we expect to have about 20 million lives covered by the end of next year. And so with that information, what we've been able to gather is that these companies are saving about 84% on their orthopedic expenditures. That 99% of the patients who've had the procedure would do the procedure again instead of having a surgery, showing that they've had a successful result. And as we collect more and more of this data, we're going to be able to present it to some of the commercial carriers like Blue Cross and hopefully ultimately Medicare. I'd love to get the Veterans Association interested in this. But really 65% of the working population is actually insured through a self-funded, self-insured employer. So if you work for example, John Deere, or let's say Hy-Vee supermarkets in the Midwest, they're like the Publix of the Midwest. If you're a cashier there, you can get our procedures covered for you. So we feel that that's quite a big deal, and we want this to be accessible to everybody. We do have financing options as well. We do work with a company that can help you get financing for the procedure. We didn't have that for a while, but we do have it now, so be aware of that, please. Additionally, let's see, some people said there's not enough research, and I agree in a lot of ways there isn't enough research. There's never enough research, and we're working hard to continue to collect the research and publish the research. And we have quite a lot of publications actually at this point. And too far, well, I guess that's all relative. Some people travel to us from outside of the country, from throughout the United States, from around the country. So we have facilities in Florida, but also in other states, other Regenix affiliated clinics. So thank you for participating. We'll go ahead and end that poll. And I'm going to go on now to talk a little bit about, so why choose Regenix? I think I've been obviously touching on this for quite some time. I wanted to be able to show you this video. It's called the Regenix Difference. It's an animation, but it really summarizes a lot of the information that's necessary to understand why Regenix is really different than anything else that's out there. So if you can get a chance to watch this video, it's called the Regenix Difference. I think if you type that in, or if you use this website URL, you'll be able to find that video. I have a question from a patient out there, potential patient, actually he's a former patient, I know him, or a current patient. It says, are there Regenix offices in Portugal? If so, is the advanced procedure with cells multiplication allowed there? So as far as I'm aware, there are no Regenix offices in Portugal right now. I know other countries are experimenting with various types of things regarding stem cells. For example, I was recently in Brazil, in Sao Paulo, working with surgeons and interventional radiologists in the hospital, helping them start up a clinical trial for stem cells and platelet procedures. And so other countries are working at this. There's a lot of skill needed for this, and it takes time. And so those physicians there were not quite ready to do this. But with enough practice and enough attention to doing this right, I think they're going to be able to do this well. We do have facilities throughout the world, not as many, of course, as there are in the United States. And you can check on the Regenix's website for locations tab. Click on the locations tab, and you can see all the facilities throughout the world. Regenix is really the inventors of this field of interventional and regenerative orthopedics, and they started a not-for-profit educational foundation so that we can teach other physicians how to do these procedures properly. We believe as the biologics and delivery of devices and methods continue to improve, that most of the orthopedic surgeries will be replaced by these precise needle-based procedures, and we believe that should be happening at this time. Our goal is to use less invasive procedures to avoid the need for more invasive procedures. And the key really is accuracy, and that's where a lot of the skill comes in. And we need to be using image guidance. That's a key, and we need to be skilled at using that image guidance. We have to get it right into the tissue. Regenerative are the world leaders, the longest and best safety record, the most publications. All the physicians are musculoskeletal medicine experts who are highly trained in the use of ultrasound guidance and fluoroscopic injection skills. All, of course, board certified in a musculoskeletal specialty. The training is standardized, the protocols are standardized, and we are sharing best practices amongst all the doctors throughout the country who are part of Regenerative. Publications are very, very, very important for validating a concept and for validating a procedure. And Regenerative is doing the heavy lifting. As I mentioned, more than 50% of the world's literature is through Regenerative. There are many, many publications and many more on their way. Regenerative also has what's considered the highest level of a study called the randomized control trials. They have some of those that are ongoing and publishing on that. And of course, publishing on safety, which we already touched on how important that is. And the quality of what we're producing is substantially better. I mean, the platelet products and the stem cell products are completely in a different category than what is typically being produced by just spinning it down. We are able to produce products that make up 15 to 20 times more stem cells without violating any FDA regulations. We're constantly upgrading our protocols and advancing these. Regenerative Laboratory is second to none, university-style laboratory, but is 100% focused on getting stem cells to work better. So we're constantly having breakthroughs that we're implementing into our practice. Again, I mentioned early on that there's a facility in Cayman Islands where we can take the stem cells and grow them into larger quantities. That's called culture expansion, or it's also known as Regenerative-C, which stands for cultured expansion, or maybe it can be in this case, it can also stand for Cayman. For certain conditions like a very advanced hip arthritis, the results are better down in Cayman. So the reasons to do it in Cayman would be it is the most advanced procedure. You get the highest amount of stem cells by 100 to 1,000 times. You can store the stem cells for future use, so you can take your current age of stem cells and use them in the future. And you can treat multiple body parts at the same time, potentially, because you have so many more stem cells available, which is harder to do here in the United States. And everything there is a very advanced laboratory, actually very impressive laboratory where everything is done. And all the stem cells are tested for genetic abnormalities before they're grown. So safety-wise, we were touching upon this here. This paper had 3,000 procedures in it over a 9-year period of time. And in general, what we're seeing is no serious side effects as seen with surgery, and it's as safe as any other injection procedure, as I mentioned. Statistics on knees. Knees do very well. Even people who have been told that they are knee replacement candidates, we're seeing about 90 to 95% of patients, even in that category, that severe category, are telling us that they have improvement when they're tracked over time. And this is sustained over longer periods of time. I tend to put platelets in the knee once a year as a maintenance strategy for people with very advanced conditions. But in general, we're seeing that sustained. And in our office, we're seeing an average improvement in pain and their ability to do things, their function, ability to do the things that they want to do, of about 60 to 70% improvement in that. So that's considered to be quite a successful procedure, especially for a condition that is that advanced. But we're seeing also quite good results with meniscus problems and ACL tears and such. It doesn't seem to be related to the degree of arthritis. People can do quite well with advanced arthritis or their age, although I do have some concerns as we get people into their mid to late 80s and 90s. we have some other options that I think may be a better choice. And even people who are heavy can do quite well. We don't see a difference in the statistics in people who are heavy. ACL tears, this is really, really, really remarkable. I think we're seeing things where previously either had to live with looseness in the knee or you had to have a surgical procedure, period. And when there's a full complete tear, like you're seeing here on the right, the knee is very, very loose. But it can be loose, very loose with a partial tear or what's called a complete non-retracted tear. That is, it's torn almost all the way or all the way, but the two ends are still together. Even in those cases, we're able to see ACLs grow back together in many cases and grow back together in a strong way. And Regenerative just published a recent larger case series of patients who've had this with pictures pre and post of MRI that show that this ligament is regrowing. And so this is really, really exciting for us. This is just an earlier paper that showed, if you look here where the yellow arrows are on the left part of the screen, there's a very indistinct looking grayish structure that follows the outline of that, whereas the right is the same patient, and you can see how it's a black, straight structure. That's considered to be basically a normal appearing ACL on the right, and an extremely abnormal, if not completely torn, ACL on the left. Knee meniscus do very well. Shoulders can also do very, very well. We're treating arthritis and rotator cuff tears and labrum tears in the shoulder very commonly. And what we're seeing on average is about 70% of patients report more than 70% improvement in pain and function. And at this, just putting in the time point of 1.5 years, but it can be sustained for much longer than that. In rotator cuff tears, depending on their size, those can regrow, or we can just improve the quality of all the tissue around the joint such that the person doesn't feel limited anymore. So we see people who are doing better than this, but this is kind of the average because it includes people with very, very advanced conditions as well. This is a randomized clinical control trial showing that our procedure for rotator cuff tears is better than exercise. And that's something that needs to be proven because exercise, physical therapy, that is a standard treatment for rotator cuff tears. And so we want to be able to show that we're better than that, and we are. As a matter of fact, there are papers showing that surgery is not. So we're seeing some good results, and this is high quality evidence that's going to be published. On the back, we treat pinched nerves, spinal stenosis, disc tears, much better than cortisone injections. And for people with disc-related pain like I had, it can be life-changing. And a lot of people are getting fusions for things were less severe than I had. Very common to get large lumbar fusions. We treat degenerative disc disease and degenerative joints and loose ligaments. They kind of usually all go together. This is quite a beneficial procedure, and most of the time we don't usually have to use stem cells. We can just use platelets for that. If there's a tear in the disc, as I mentioned, this could be, and the person has clear pain coming from that disc, this can be quite a successful procedure. Can change them around. I'll give you an example. We have a patient who is a preacher who was having severe, constant low back pain. The pain was worse with sitting. That's what we see with disc tears, similar to what I had. He was struggling in his work. He was struggling in his recreational activities. He wanted to be he was a recreational volleyball player and swimmer, and he was struggling with all those activities. And we finally ended up, in his case, doing stem cells into his disc, and he had quite remarkable results, and he's still doing very, very well with that. He's back to doing all the things that he wants to do. He actually became a good spokesperson for us. He actually had the procedure covered for him by Samaritan Ministries here in Florida, which is a Christian cost sharing plan. So we were really excited to have that procedure covered for him to give him the results that he was looking for. This is just a paper showing that use of the culture expanded stem cells inside of a disc with showing bulging here. I'll point that out. You can see this is the disc here, and there's some bulging coming out here around the spinal cord. And then this is a follow-up MRI showing that that bulge actually retracted with that particular procedure. So we also treat commonly thumb arthritis and ligament and arthritic conditions in the foot, and a lot of tendon problems commonly in the elbow. These are common things. Platelet injections can work quite well. This is a paper that was not Regenerative published. We're seeing similar results, perhaps a little bit better. But almost any tendon problem, small to moderate tendon tears or tendon degeneration, what's called tendinopathy, golfer's elbow, jumper's knee, Achilles problems, even rotator cuff problems and so forth, hamstring problems. Tendons on the side of the hip are a common thing we see. That about 82%, in our case, I think it's a bit higher. We can see moderate to complete resolution of symptoms with anywhere from 1 to 3, just platelet procedures without having to go to a stem cell procedure. So platelets can be quite effective, and we'll tell you when we think one is a better option for you than another. So just to finish up here, this will take me another 5 minutes and we'll be done. I appreciate everybody who's sticking it out with me. I know this is a long presentation, but like I said, I wanted to make sure we got it all recorded. You're going to have a 60-minute or more evaluation with a physician. It's very thorough. We have a lot of questions to ask you. We have a very thorough examination. We're going to probably evaluate your, we're going to do obviously a physical examination, probably like you've never had before. We're going to do a diagnostic ultrasound exam a lot of the time to look at the tissue real time. And then we're going to have a discussion. We're going to talk about treatment and management strategies, risks and benefits of different choices, defining your goals, defining the barriers to those goals, and discussing whether you're a candidate or not a candidate. And this is quick slides about what the Regenerative SD, which is the same-day stem cell protocol, looks like. Typically, it's the orange boxes make up a stem cell protocol. That is if you have an arthritic condition. If you just have a tendon condition, then it's just this middle box that says phase 2 re-injection. Oftentimes we can get away with just that. So, but most of the time, the SD procedure is made up of phase 1, phase 2, and phase 3 injections. These are spaced 2 to 5 days apart. As an example, in my schedule in Sarasota, I do procedures on Tuesdays, Thursday, and then Tuesday. That's how that would go. In Tampa, when I'm doing procedures there, it would be a Monday, Wednesday, Friday in my schedule. Each doctor has a little bit of a different schedule, but just so you have an understanding. So we're talking about the phase 1 is called the pre-injection, phase 2 is called the re-injection, and phase 3 is called the post-injection. So phase 1 is a blood draw typically, and we use some prolotherapy solution as a way to strengthen ligaments and tendons and to get the tissue ready for stem cells. So it's a preparation phase. We call it tilling the soil. Next, in the morning, let's say if we're doing the schedule, I said Tuesday, Thursday, Tuesday, so this would be the Thursday. There'd be a bone marrow aspiration as I described in the morning. You'd have to be fasting for 3 hours for that. And then in the afternoon, we do what's called planting the seeds. This would be the actual placement of the stem cells. And by the way, whenever we use bone marrow-derived stem cells, we're also going to be using some of your growth factors from your platelets and platelets to work with the stem cells. They need to work together. The bone marrow, these are the areas that we get the bone marrow from, and I already described that procedure earlier. I promise you is not a painful procedure, mildly uncomfortable at the worst typically. We may recommend a brace, probably going to need some pain medication after that. And then the phase 3 post-injection is where we get additional amounts of platelets from you. This is through an IV, through a blood draw. And this is going to act as a fertilizer. We want to place this in the area where we place the stem cells to function as a fertilizer. We know that growing stem cells is difficult. Regenerative has a lot of experience growing them in the laboratory. And if you do not fertilize them with these growth factors, their growth rate really starts to plummet. So we like to be able to do that. So all 3 phases are very important. Actually, the concept of having all these 3 phases is a patented concept, as well as a lot of the individual things we're doing. So we want to have a preparation phase, the actual procedure, and then the fertilization phase. And there may be some other things that we can do within these phases, like we may recommend what we call bone augmentation. There may be times going into the bone in certain conditions may be beneficial. I recommend using an amniotic tissue product along with your stem cell procedure. And then we also have another product we didn't even talk about called A2M, which has a lot of value. Again, A as an Alice, 2M as in Mary, A2M. And that product we make from your blood, and it has a synergistic effect with what we're doing, or we can use it as an isolated treatment. And we can talk about that in person when you come in. Okay, those were the 3 phases. I think that's all I need to talk about regarding those. And just to finish up here, as I mentioned, first few days is a fair amount of inflammation and pain. We're going to help you through that. Then somewhere in the 6-week to 3-month phase, we start to see a real noticeable improvement in terms of your level of pain and in terms of your function. And that improvement will continue on 3 months, 6 months, 12 months, and then it'll start to plateau. And what we would expect and what we typically will see is that you have a new, better baseline. You may not be 100% improved, but maybe you're 70, 80, 90% improved. And that becomes the new baseline. And that becomes a very meaningful improvement to people, typically speaking. Okay, and last slide, lifestyle recommendations, or be aware that part of our consultation with you, we're going to give you recommendations of things that we think you should do to help your particular situation. So it's going to be individualized to you. There's some general recommendations we make to everybody. We're going to look at your particular medication set, because certain medications do seem to interfere with stem cell procedures. So we're going to ask maybe to make modifications or replacements with other different medications to work with your prescribing doctor on that. And ask you to stop smoking. We'd like you to eat healthy. We may ask you to do some types of exercises in advance of the treatment. As you can see here, there are certain supplements that we think may be helpful for the procedures. Reducing stress, sleeping. These are all things that can impact your body in various different ways, and we'd like you to optimize that for a few weeks prior to the procedure. Okay, I think I'm going to end it there in terms of the slides, so I'm going to stop sharing the slides. If I can figure that out. I can stop sharing. That brings me up on the screen. And I'm going to see if you have any questions. I'll spend a little bit of time seeing if I can answer some questions for you. I went ahead and answered one of those already. And if anybody has any other questions for me, I'll go ahead and answer them at this time. Okay. Somebody giving me some advice on how I could have gotten that video to run. I'll know that for next time. I appreciate that. Somebody telling me they already have an appointment. That's great. More info about the success rate with hips. Okay, that one just popped up here. Can you go ahead and tell me a little bit about, just type it for me, and I'll, I don't want to, just type for me what your condition is, and I'll give you a little bit more information about what our success rate is for hips. And I got a thank you from a patient who's going to be seeing me soon. Appreciate you joining us, and I'll be seeing you soon in the office. And I'll just say first name John. If you can tell me a little bit about your hip, I can give you a little bit more information about success rates for that. Okay, arthritic hip with loss of cartilage. Has anyone told you, John, that this is considered to be severe or mild, moderate? Have you heard? Okay, so I'm waiting for an answer on that, but I'll go ahead and just told he needs a replacement. So presumably, if he was told he needs a replacement, then that's considered to be a severe condition. We have been having more and more success with advanced hip arthritis. Advanced hip arthritis, of all the things we treat, is the hardest thing to get a good result with. I shouldn't say that. It takes more effort to get a good result, more things that we need to do on our part. And the results are less consistent, but we have seen very, very good results. I have patients. I saw a lady just 2 weeks ago. I had treated her hip 1 year ago. Again, she was told she needed a hip replacement. She's 68 years old. She was a professional acrobat years ago, and now she's trying to do recreational dancing and trying to teach a tap dance class, and she was unable to do it because her hip got so bad. And so she came to see me. Again, she was limping, told she needed a hip replacement. We ended up doing the procedure. We had to do a bunch of different things to kind of be a little bit more aggressive when it comes to advanced hip arthritis. And then I saw her back 2 weeks ago after a year, and she's doing phenomenally well, 80% better. And she's able to tap dance and teach tap dance 3 times a week, of all things. It's amazing. We've had a lot of stories of people with advanced hip arthritis who are doing well. Early on, I think we struggled a bit in getting the results. We were seeing kind of what the national statistics were showing, that, maybe only 1 or 2 out of 3 patients with advanced hip arthritis were getting some sort of decent results, 30, 40, 50% improvement. We've been a lot more consistent in our results, people getting 50% or 60% or above improvement in their pain and function on a more regular basis now, sometimes 70, 80, or 90% improvement. And I think what we've done is make some modifications in the protocol, been a little bit more aggressive in the way we're treating certain things. A lot of times hips, when they get to be the advanced stage, they actually have swelling that's in the bone. So they're swelling in the ball and maybe sometimes in the cup side of the ball. And we actually need to go into the bone itself to place the stem cells in those areas. When they're swelling in the ball, those are considered to be little micro fractures in the bone. And so we really need to place the stem cells into that tissue. That requires a fair amount of skill. If we have to go on the ball, then we really need to put someone to sleep for that. And we use an anesthesiologist who just gives a little twilight sleep. So that may be something we need to do, sometimes using the amniotic tissue with the stem cells, or using this new product, A2M, we've been using for some time now as well, all kind of combined together. With that, we've been getting pretty good results with advanced hip arthritis. So I certainly wouldn't discount it. If you have a hip replacement, chances are you'll have a pretty decent result. Likely may need a revision in the future. The thing is, you take yourself out of the pool of people who can have anything in the future. Once you've had a hip replacement, you're no longer a candidate for anything that we do pertaining to the hip joint. Maybe the tendons on the side we can still treat. So I'd be careful about that, because the technology is advancing fast, and there are things we can do for you today to keep you comfortable as the technology continues to advance. So hopefully that answers your question, John. Anybody else have any other questions? Or John, if you have any other questions, I'd be willing to answer those. Okay. Okay, looks like you've got an appointment with one of our doctors already, so I appreciate that you're going to be doing that, and hopefully he can help you with that information as well. You certainly can tell him what we discussed here today. Anybody else with any other questions? I see some names I'm familiar with on this list here. I don't want to call anybody out by name, but former patient of mine, I see that you're on here, and you must have some questions if you're on here. Okay, well, I appreciate everybody attending, and hopefully this was valuable to you. We'll archive this at some point and make that available. We'll do other live webinars as well. I promise I'll get better at this. This was our first one, and we'll be able to show the videos, and hopefully I can tailor it to be more useful to you as well in the future, but hopefully this did give you some information that you found valuable. Anyway, thank you for attending, and I hope you have a great evening. Thanks. Bye-bye.